Thank you for so much, Dr. Michael Twyman, for your patience today. And we're excited to be talking about the biggest longevity hack we know about vascular support. My name is Diamond Fernandez, as I mentioned, and I'm your founder and director of the HeartFit Clinic. And we have clinics, of course, in Calgary, Edmonton, and Vancouver. And yes, I'll be the first to tell you we're going to be out in Eastern Canada, in Toronto and London here shortly. So I'm going to introduce Dr. Michael Twyman. So he is out in St. Louis, Missouri, and he's a board-certified cardiologist who has now become a preventative cardiologist. And that's kind of an oxymoron, and we'll get into that conversation a little bit more when we go into this. But in 2017, he discovered about biohacking and has been using the modality of health optimization to help patients make incremental changes to their lifestyle and environment to improving their heart health and overall health over time, including photobiomodulation. And so this is really important stuff, and I'm really excited to be moderating this webinar. So welcome, Dr. Michael Twyman, to the call today.
Thank you for the opportunity to chat with you guys tonight.
Excellent. Well, I'm gonna let you take over, and you can get organized with that. For those of you who have any questions, again, there's the chat window on the side, and we'll get started.
All right. So as you said, I'm Dr. Twyman. I'm a board-certified cardiologist. My practice is located in St. Louis, Missouri, and I'm definitely focused on heart attack and stroke prevention at this stage of my career. I was an invasive cardiologist for many years and treated many heart attacks, strokes, heart failure, patients very sick in the ICU. And so I know how bad it can get if you leave your vascular system unchecked. And so in 2019, I launched my own practice where I really went upstream and was really looking at the root causes of vascular disease. And then the glycocalyx was something that I became aware of a couple of years ago, that if you really keep that layer healthy, you probably don't end up in the cath lab many years down the road. So tonight, if you don't know what the glycocalyx is, you will leave with an understanding what it is and what you can do about to try to keep it as healthy as possible. So as already stated, I founded Apollo Cardiology back in 2019. The reason it's Apollo is that Apollo was the sun god, and I'm very big into circadian biology. I help my friend out, Dr. Lyon, with her Institute of Muscle-Centric Medicine. There's a quantum biology collective that I've taught in lectures for, and I worked with Calroy in the past with previous projects, including webinars. So what are your health goals? Do you want to play tennis when you're in your 80s and 90s? Do you want to be able to hike up a mountain? Do you still want to be intimate with a partner? Do you still want to be able to get down on the floor and play with your grandkids or maybe even your great-grandkids? Well, you're going to need to have a healthy vascular system to be able to do that. Vascular disease is still the #1 thing that kills men and women. In the United States, at least, every 40 seconds, somebody has a heart attack. And often, many of these heart attacks are the first sign that the person has vascular disease. It's the most common disorder globally. And while certain metrics in cardiovascular health are improving, it's still way too many people having these issues. And this is why one of the reasons I stepped out of the cath lab, because if it was all about, taking a blood pressure medicine, aspirin, and statins, we'd all be doing it, and nobody would have a heart attack anymore. So we had to be missing something. And in women, their health, is often sometimes a little bit more challenging to uncover. Is it a vascular cause? Because they may be told there's a gastrointestinal cause or it's psychosomatic. But vascular disease in women is also the #1 thing that kills them at an earlier stage than they really would prefer. Breast cancer is something to be worried about, but you have at least an 8 to 10-fold more increased risk of having vascular disease than you do breast cancer. And women sometimes present differently. They don't have the classic elephant on their chest or shortness of breath. They may just have fatigue or exercise intolerance. And so you have to go looking for vascular disease before they have symptoms. And when women go through perimenopause and menopause, and they start having shifts in their estrogen levels, then the risk of vascular disease starts equaling that more of a man. Estrogen is cardioprotective. It helps dilate the arteries. It helps with the lipoproteins, often keeping the LDL particles lower, the HDL particles higher. And if you have elevated LPLA, which is a genetically inherited lipoprotein, it can generally keep LPA lower. And then when you lose estrogen in menopause, LPA levels tend to rise. So your health goals depend.
Sorry, just interrupt you, Michael.
Sure.
Especially going back on that slide with women and heart disease. I can't tell you how many times we just had a female come into our clinic, and she went to the hospital presenting with, actually, she didn't go present to the hospital yet. She actually went to her dentist, and was having teeth pain and jaw pain. And she's like, I went to the dentist first. Anyway, ended up going to the cath lab eventually, like after some discussion point. She goes, it's getting too much because now it's there, but it's also coming down the back, like the spine is feeling poking. So the symptoms were, but it was ailing enough for her to eventually go to the cath lab. But the teeth were the first thing that was affecting her for a few weeks prior to that. Anyway, she ended up having a big lesion down her LAD, but it was something that's super important. But women, gosh, I can't stress this enough. Like sometimes we get the couples coming into our clinic and the women are more at risk than the man. And of course, women have this inherent nurturing effect to be able to make sure their husbands are okay, but you also got to make sure that you're okay. Like obviously putting your own face mask on before anybody else's, right? So it's the same analogy applies to the family, because gosh, to be a woman nowadays it's super powerful. Like, I mean, going through childbirth to going through perimenopause to menopause, all those type of things, it's a big deal. And we're going to be doing a webinar just on women as well. But I can't stress this enough, especially with women and heart disease, because I can't tell you how many cardiologists dismiss the fact that, oh, it's anxiety, or, oh, it's nothing big, don't worry about it. You pass the stress test. And we'll talk about that a little bit later, but everything's okay. And so anyway, I just wanted to add that piece in on that side of the thing with women. So.
No, and that's a great point, is that, just because you don't have the classic elephant on your chest, sensation, you shouldn't dismiss these symptoms that are nagging, especially if they're being brought on by physical activity. If you're exercising and something doesn't feel right and it goes away within a few minutes of you stopping that activity, it may be your heart. You need to go get that checked out.
Absolutely.
So your health really depends on having a healthy vascular system. And I always tell people, it's an amazing fun fact, nearly 60,000 miles of blood vessels, arteries, veins, and capillaries. 99% of your blood vessels are going to be in the microcirculation. These are blood vessels that are smaller than a human hair. It's reported that you can put up 100 of these blood vessels in the diameter of one human hair, and they're all very important. They're bringing oxygen, nutrients into your tissues, and they're bringing waste products out of them. Lining your arteries is a layer called the endothelium. It's one cell thick. That endothelium is like the air traffic controller, which determines what stays in the lumen where your blood flows and what has access to the arterial wall. If you're able to strip out your endothelium from your lining of your arteries, it would be approximately the surface area of 6 tennis courts. So it's one of your largest organs that you probably didn't even know that you had. In the 1960s, they developed certain scanning microscopes that were able to start visualizing the glycocalyx. The glycocalyx is what protects the endothelium. The glycocalyx is a protective gel coat. Here in this picture, you can see this gel coat. And in this dark field, this is the red blood cells zooming by in the lumen. Using different microscopic techniques, you could actually see these hair-like projections. I was just recently in the Low Country in South Carolina, and this looks very much like the marsh. The marsh has all these different organisms living in it. That's going to be an analogy you're going to start hearing me talk about more and more. Sometimes I talk about the seagrass, but this is the glycocalyx here. It's has these different compounds in it. And for a while, honestly, it took me a while to be able to pronounce these without stumbling over them. But these are the glycoproteins, the proteoglycans, and then the glycosaminoglycans. And they line the whole layer of the 60,000 miles of blood vessels. They're easily damaged, but we're going to show you how you can repair them as well tonight. And endothelial dysfunction, which essentially is a marker of vascular disease, it's the first sign that there's a problem with your arteries, is when the arteries can't release sufficient levels of nitric oxide. That is one of the major jobs of the endothelium, is to release nitric oxide. The nitric oxide gas causes the smooth muscle here to relax. But if the glycocalyx is getting damaged, then the underlying endothelium is not able to release that nitric oxide. The arteries start getting stiff, and then you're set up to potentially start developing plaque in your arteries. So what does the glycocalyx do? Well, again, it's kind of like that kind of riverbed or marsh. It's going to be something that prevents certain things from sticking to it while housing other things that are going to be beneficial. If you were to be injured, you want to have the clotting factors readily available, but you don't want the blood to clot all the time. You want the red blood cells to be carrying oxygen to the tissues, but you don't necessarily want the lipoproteins, which are ferrying cholesterol through the blood vessels, to get retained in the artery, because that can kick off a cascade where inflammation will occur in the artery wall. These foam cells build up, and you start developing more plaque. So again, think of the glycocalyx as a protective gel coat. There's many things that damage the glycocalyx. There may be up to 400 things that damage them. And the traditional risk factors, which we're all aware of, high blood pressure, high blood sugar, including diabetes, smoking, dyslipidemia, and obesity, those are 5 things that could potentially damage the glycocalyx. But there may be up to 395 more. So you have to go looking for them with a good history, physical exam, biomarker testing, and then there's different biophysical testing that you can do as well. Toxins. I was recently on a podcast and we were talking about microplastics. We're all exposed to plastics, but why do some people have the plastics damaging their arteries enough where the plastics are built up into these plaques? Well, at some point, their glycocalyx and their underlying endothelium were injured, and the plastics were able to get retained in the plaques. Hormonal imbalances. We talked about it at the beginning of this. When estrogen drops, people's nitric oxide levels tend to drop. If you lower your testosterone enough, you may start losing muscle mass. Your muscles are basically your metabolic engines. Chronic inflammation. You have periodontal disease, untreated sleep apnea, chronic gut infections, Lyme, mold, something that is activating your immune system chronically. That inflammation causing different interleukins and cytokines, those compounds can then scratch and damage that protective gel coat in your arteries. And as mentioned, 2 of the bigger things that damage the glycocalyx is elevated blood pressure and elevated blood sugar. These glycosaminoglycans, they are very fragile. High blood pressure will basically shear them off. And you can actually measure some of these, the sinicum 1s and the hyaluron sulfates in the urine and the blood. Now, these are not commercially available at this time. There are research studies that use these in patients who are very sick with sepsis, a blood infection, and the patients who have higher levels of sinicum 1 and hyaluron in their blood or urine, they tend to be sicker patients in the ICU. But it's not yet a clinical thing that we're following. What else damages the glycocalyx? Elevated blood sugars and insulin. A lot of the glycoproteins are very sensitive to the high blood sugar. And once that protective gel coat is damaged, then the lipoproteins, the white blood cells, they have access to the underlying intima. And then this can kick off the cascade where basically it's like a game of Pac-Man. The white blood cells start gobbling up the cholesterol particles. This area starts to swell, soft plaque, hard plaque, and then potentially plaque ruptures may occur at some point. But also when you disrupt this glycocalyx, these different clotting cascades also get released. This is one of the major reasons how COVID was injuring so many people. It was damaging the glycocalyx in those patients, and those clotting cascades got activated. So there's 2 key insights I wanted to share tonight. One, the endothelial glycocalyx is both fragile, but it is resilient. It will rebuild itself if you get out of its way. And there are commercially available seaweed-derived sulfated polysaccharides that potentially help restore the glycocalyx. And the reason the sulfate is important is that the glycocalyx is heavily full of what's known as structured water or EZ water. And when you sulfate something, it's able to hold on to more water.
So, Dr. Michael, Dr. Twyman, when you look at this side of things and when you learn about the glycocalyx, I just want to point something out that's very important because I just got back from the European Society of Cardiology, and I was talking about what we do as a clinic there and what's going on. A lot of cardiologists are completely clueless in terms of the pathophysiology of an artery wall. Can you comment on what you learn in med school versus what you're learning now in terms of the pathology of the artery wall?
I mean, I think for my basic kind of med school classes, I mean, we learned that there is an intima, a media, and adventitia. And, we didn't learn much about the endothelium, and I never heard of the word glycocalyx in my entire medical school career. And we would just be taught that like something damages the intima, plaque starts building up, and we treat those plaques with medications and stents or bypass surgery. We never really thought about the protective lining and that what was actually, getting injured first.
So, and you yourself made the switch from interventional cardiology. So just for the listeners out there, that's the person who is in the cath lab when you're having a heart attack to insert a stent or to see where the blockages are. What made you, like, you're damaging, can you talk about the angiogram and when you're doing that invasive test, how much you're, like, when you should do that? Because a lot of people think that hey, I want to go look at the plumbing. I want to be proactive and make sure I want to do that. Can you comment as to why you don't want to do that now that you know the pathology of the artery wall a little bit more, and why you made the switch from, really, like I said at the start of this talk today, is that it's an oxymoron when I put cardiology and prevention together, because that's not really the focus of what you went to school for. So I know I asked a few questions there, but quickly
Oh, no, I
commenting on
got them. So, slight correction is that I ended up bailing out from the cath lab before I went down the interventional fellowship. So I was an invasive cardiologist, meaning I would do my own coronary angiograms. And if I thought the patient had enough stenosis, then I called in one of my colleagues who would then,
Yeah.
do PCI. So, but during an angiogram, we would thread a catheter generally into your radial artery on the side of your wrist or your femoral artery. And then we would put contrast in the arteries to take a picture, which was basically a luminogram. And we would just basically be able to tell you how much blockage we visualized and thought we seen in one of your three major coronary arteries. But the challenge with a regular angiogram is that you don't see anything in the walls of the artery doing that part of the test. Plaque is kind of like an iceberg. It's growing in the wall of the artery, and only until much later does the tip of that iceberg poke up above the ocean surface and start occluding the blood flow in the lumen. And by the time you develop symptoms that you're showing up at a cath lab because you failed the stress test, you generally have a 70 to 80% blockage in one of your arteries. But unfortunately, half the time somebody has a heart attack, those blockages are less than 50%, and you generally don't feel those until they rupture. Like again, of these plaques as being like a pimple on the artery wall. If they pop, then all that damaged cholesterol, cellular debris spills out to the blood clots. Now you have 100% blockage. And then one of my colleagues is going in there, passing a wire past that blood clot, using a balloon to get it out of the way, and then often leaving a stent to restore blood flow. But why did I switch from that kind of model to what I'm doing now? It's because in my training, we would see the same people coming back every 6, 12, 18 months. And we were basically playing whack-a-mole. They get a stent in their left anterior descending artery, and then to be their second diagonal, and then it's the OM2, and then it's the right coronary artery. And we never truly fixed people with stents. We'd make them feel better. And if they're having a heart attack, yes, it can stop the heart attack and potentially save their lives in that instance. But we weren't stopping atherosclerosis at that point. And so I was just getting more and more curious, like, what are we missing? And eventually stumbled upon functional medicine. And so now I more consider myself like integrative cardiologist where, yes, I trained in the Western medicine world and those tools are needed for some people, but hopefully not all or not many. And then really trying to get to the root cause why people have vascular disease. So I had to basically be like, I was in the matrix. I know how bad it's going to get. And if you follow this roadmap, you're going to keep going down this pathway. If you keep your glycocalyx and underlying endothelium healthy, or if it's damaged in the past and you repair it, you're not going to end up in the cath lab in the middle of the night having an event.
Yeah. Anyway, I just wanted to talk about it because, like I said, many cardiologists have zero idea about the pathology of the artery and what the actual biochemistry happens to actually cause atherosclerosis. And that obviously is, and don't get me wrong, you want a cardiologist on your corner when you are in an emergency situation, when you're having a heart attack or you're in heart failure or you're having a valve problem, whatever it is, like that's important in an emergency situation. But yeah, in terms of prevention, yeah, I mean, you covered it pretty well there. So
well, thank you. All right. So what are some of these glycocalyx regenerating compounds? Well, many of them are marine based, and they were looking at certain compounds that would potentially be building blocks to regrow this protective gel coat in the arteries. So that long word, GAGs, the glycosaminoglycans, there are certain things in these marine-based polysaccharides that mimic the glycosaminoglycans. And so these have been studied and then were trialed out and been shown to be effective and safe. So there is a product that has ramenan sulfate in it from a seaweed called Monostroma nitidium. Again, the sulfated part of it is important. That's what allows the glycocalyx to hold on to water. And the ramenan sulfate is extracted from this algae. So they had done a study, the references are on the bottom of the screen, where they had given patients ramenan sulfate 30 minutes after they had eaten, and then measured glucoses versus people who had not gotten the ramenan sulfate. These were done in healthy individuals, so they were not diabetic. And the 30-minute postprandial or after eating meal glucoses were statistically lower than the people who did not use the product. So this was a and a preliminary study that suggested that potentially Ramadan sulfate would be helpful in diabetic patients by lowering glucose. Again, earlier said, higher glucose levels tend to damage the glycocalyx. So there is a device called the microfluidic chip. Think of it like a glycocalyx on a chip. They're able to test different compounds to see what damages the glycocalyx, but also importantly, what may help regenerate or regrow it. So it's trying to mimic the small vessel size. Previously mentioned, the microcirculation is less than 1/100th of a human hair's diameter, and they can also put different flow through this device. So if you have elevated blood pressure and elevated shear stress, that's going to damage more of the glycocalyx. So they can mimic it with this microfluidic chip. So the Ramadan sulfate is a powerful antioxidant. It was also studied that there's different seaweeds, that like our brown seaweeds, for example, that have fucoidins in them. But the Ramadan sulfate was just been shown to be a little bit more powerful in a lot of these trials. So this was another study that was actually done with the chip itself, and it showed that there was less glycocalyx damage. I should say it improved the glycocalyx up to 103% more than its baseline in only 24 hours. So again, the glycocalyx is easy to damage, but it's also, if you get out of its way and you give it the right building blocks, it's easy for it to start regenerating. And as of this time, it's very well tolerated in individuals, and there's no known safety concerns and no known drug or drug supplement interactions that have been demonstrated. As stated, the glycocalyx is resilient, it's easily damaged, but it's easily restored with proper support. I mentioned earlier that there may be up to 400 different risk factors that can damage the glycocalyx. The glycocalyx damage occurs before the underlying endothelium becomes dysfunctional and not able to produce enough nitric oxide. The nitric oxide is what dilates the arteries, so that helps keep blood pressure normal. Nitric oxide is what prevents the lipoproteins and the white blood cells from sticking to the artery in the first place. Ramadan sulfate from Monostrom indicatium, it's a powerful and safe glycocalyx supporting compound. It helps rebuild that gel coat, that force field of the arteries, and a healthy glycocalyx is foundational for vascular wellness. So I think the last two things are just kind of talking about, having a nice car, just think about like having a nice road. So you need a nice glycocalyx for the car to be able to go 200 miles an hour. So why do you need nitric oxide? Mentioned a little bit, I want to say, what do you want to do when you're older? Do you want to be able to exercise? Do you want to be, sexually active? Well, you need a healthy microcirculation. I've learned it from other people, but there's a saying, ED equals ED. If you have erectile dysfunction, you're going to likely have endothelial dysfunction. So if a man has erectile issues, which when you're 40, there's a 40% chance you could. If you're 70, there's a 70% chance you can. It's not necessarily that, should be embarrassing, but it's something that tells you that the check engine light of your microcirculation is tripped. Why can't you make enough nitric oxide? Is it not enough nitric oxide coming in or destroying the oral microbiome? There's something that's causing your body not to be able to make enough nitric oxide. It all tends to go down as we age, but often there's things to be done that can help support healthy nitric oxide. Nitric oxide is needed to dilate the blood vessels to get oxygen nutrients into the brain and get the waste products out. So if you want to have optimal cognitive health, you need healthy blood flow. You need your immune system working well so you can fight off infections. And if you're exercising, you want to be able to recover. Muscle is your organ of longevity. If you have healthy nitric oxide levels, you can recover potentially better and keep going back to the gym. So there is a product that can help improve 24 hours worth of nitric oxide. So nitric oxide by itself is a very short-lived gas, lasting, milliseconds. It's a signaling molecule. It causes the underlying smooth muscle in the artery wall to relax. But as you age, there's an enzyme called the endothelial nitric oxide synthase that tends to slow down its ability to convert arginine to citrulline. So the vascular system is going to need more and more nitric oxide to maintain optimal flow as you age. So 2 key insights on this. If you want improved blood flow, you need optimal nitric oxide. There are next generation nitric oxide supplements that will support the storage, the production, and also the release of nitric oxide. often I talk about four main pillars of optimal health with patients. Many people understand the importance of nutrition and exercise. But if you miss the stress management portion of it and you're running around stuck in fight or flight all the time with high cortisol levels, that high cortisol is going to drive higher blood sugars and damage the glycocalyx. So you got to learn to meditate or do deep breathing exercises or heart math or whatever you like to do to be able to dial back that sympathetic surge. And then one of my areas of expertise and things that I focus heavily on with my patients is optimizing their sleep. Your mitochondria, they are the engines. They only repair while you sleep. So if you short sleep yourself chronically, your car is never going to go 200 miles an hour the next day when you're putting in all this premium fuel. So you have to sleep well if you want to age well. And so getting back into what are your health goals? You want to be active, you're going to need healthy nitric oxide, healthy glycocalyx. You want to be intimate, you need nitric oxide to maintain erections. And if you want to be able to, be cognitively there for your grandkids and be down on the floor and be able to get back up, you're going to need a healthy vascular system. So I'm turning it over to Andy at this moment. So
I think before we do that, just quickly, Andy, before and thank you very much, Dr. Twyman. I just had a quick question here in terms of the glycocalyx, and I think it's something important to talk about. Is that when we talk about the glycocalyx, this hair-like structure inside the lining of an artery wall, and if that hair-like structure gets damaged, obviously that leads to the process of atherosclerosis, or which is plaque building up inside the lining of the artery, like the pimple analogy that you just talked about. Can you comment quickly that cholesterol is not something, because you talked about hundreds of things that can damage the glycocalyx. Can you talk about how cholesterol is not one of those factors that damages the glycocalyx, how it's a byproduct? Can you quickly talk about that part of it too?
I don't know necessarily I would use the word that's a byproduct, but if the glycocalyx is intact and healthy, and it's this structured water, this easy water that Gerald Pollack talks about, it's heavily negatively charged. The outside of the lipoproteins is also heavily negatively charged. Negative repels negative. So the lipoproteins should be sliding through the arteries like a maglev train. But if the glycocalyx is impaired for whatever reason, then the cholesterol particles get attracted to the damage, and they're partly there to do some repair, but they're more likely to get retained in the underlying intima. They basically squeeze between a gap between the endothelial cells and get retained. And then the white blood cells start gobbling up the lipoproteins as they get retained in the artery wall.
Yeah.
So it's not the cholesterol, it's the lipoproteins.
And I think that's the common misconception is people think that, hey, my cholesterol is good. I don't eat cholesterol in food or whatever be the situation. And it's not the same thing because it's not something that damages the lining of the artery wall. And you talked about that earlier. And that cholesterol is really just an innocent bystander getting used up in a negative way when the glycocalyx gets damaged and then the endothelial cells get damaged. And so that's the kind of the big point I wanted to, have you address on that side of things too. So. Awesome. Well, I'm gonna, before there's any more questions coming out there, I just wanted to allow Andy some time here to talk about, and Dr. Twyman can kind of pipe in here on just some supplements that might make sense for you to improve the glycocalyx and improve nitric oxide. And we'll go through that there, Andy. So thank you. I'll leave the floor to you.
Yeah, so just a couple of quick slides here and then we'll head into Q&A. I know we have a very active group and I can see some great questions coming through. So please keep them coming on the chat. If you go to the next slide, so basically what I want to do is just very quickly connect the dots between the information that Dr. Twyman shared with you about the endothelial glycocalyx and the role of nitric oxide in vascular health. So the way I think about the vascular system is it's a big transport system. So as Dr. Twyman said, the endothelial glycocalyx is that slippery inner lining of the endothelium. So think about a healthy glycocalyx as an investment in the infrastructure of your own body's transport system. So imagine that smooth highway, the photo that he showed you, that is allowing all the oxygen and nutrients to go to all the organs and the different systems of the body. So as Dr. Twyman shared with you, there's a product product called Arterisol HP. This is produced by Cowboy Health Sciences. I'm the president of Cowboy Health Sciences. And this is a product that's been on the market in research and development for about 20 years. It's backed by cellular, human, and animal studies. And as he shared with you in showing the microfluidic chip study, one of the things we were able to do in the development of this product is actually test different substances on the glycocalyx to see what breaks it down, such as glucose, sugar, and what rebuilds the glycocalyx. As Dr. Twyman stated, we found in our studies that this green seaweed called Monostroma nitidum was the most effective in rebuilding that glycocalyx. So imagine in 2 hours of having your glycocalyx degraded, you could rebuild it to 103%. This is what our studies are showing us Arterisol can do. So super excited about this product. It's the only product on the market with this green seaweed Monostroma nitidum. If you'll go to the next slide, going back to our infrastructure and highway analogy or metaphor, Dr. Twyman talked about nitric oxide essentially being a fast car. So imagine you have this beautifully paved highway because you're using Arterisol, you've got a nice healthy glycocalyx. Vascunox is basically putting all the nutrients and oxygen in a sports car. It's helping your blood vessels to vasodilate, be more flexible, and really optimize blood flow to all the organs and systems in the body. What we're really excited about with Vascunox is up until now, nitric oxide products have always been short-lived in action. So they either deposit a nitrate or a nitrate in the body. We are able to increase nitric oxide, but only for about 6 to 8 hours. It's a really short-lived gas. So what we were able to do with Vascunox is actually use the precursors that allow the body to store and release nitric oxide naturally as needed over a 24-hour period. So 1 dose of 2 capsules of Vascunox in the morning will optimize your nitric oxide over the therapeutic levels for up to 24 hours. So if we go to the last slide. So if you think about the 2 products together, they were really designed to work synergistically. Arterisol is absolutely foundational to anyone over the age of 40, anyone concerned about vascular health. We want that beautifully paved highway. We don't want to be trying to transport all of our oxygen and nutrients over potholed roads, right? We want to be able to have things move very smoothly and have that protective layer over the glycocalyx. So Arterisol is your foundational glycocalyx supplement. And then Vascunox is used as needed if you need additional nitric oxide supplementation. So I would love to bring Diamond and Dr. Twyman back on so we can get to some of these great questions in the chat.
Yeah, I see some great questions, but I actually have some questions for you.
Oh, good.
We go going on this side of things as well, because many people talk about nitric oxide, and I think we're still stuck in an archaic way. Can you talk about the use of L-arginine and L-citrulline quickly in terms of, you see these, I think these things marketed on whatever social media or people using archaic data to be able to focus on L-arginine and L-citrulline as a pathway to improve nitric oxide. Can you explain why going through this pathway is much better?
Yes, I will give it, I will explain it in layman's terms, and then I will invite Dr. Twyman to explain it in clinician terms, or you for that matter. So, you know, initially I would almost say like arginine and citrulline was like generation 1. Sort of if you think about your iPhone, different generation, it's kind of an old school way of thinking that we are going to increase nitric oxide levels. Certainly works, but the research really shows that once you're over the age of 40, the body just doesn't convert arginine and citrulline as effectively into nitric oxide. So we're really finding that it's kind of an outdated way, I guess I would say, of increasing nitric oxide. But here I invite the 2 of you, especially Dr. Twyman, to give the more scientific explanation.
So, I mean, my experience has been that, you know, patients who are using some of these, you know, bodybuilder pump products, you know, they're just chock full of arginine, and some people get a benefit and some don't. And so the question always is, why doesn't it work for everybody? Well, most people are not necessarily deficient in arginine, but a lot of people have different cofactors that they're low in that makes the endothelial nitric oxide synthase enzyme not work as well. So in the presence of arginine and oxygen, the eNOS enzyme is going to convert it to citrulline and nitric oxide. And so there's a thought like, well, let's give people a bunch of, L-arginine as a precursor. But if that eNOS enzyme doesn't work well, you're not going to get more nitric oxide on the other side. And giving arginine through a supplement isn't well absorbed in the gastrointestinal system. So then I thought like, well, how about we give L-citrulline and backdoor, because there's a pathway that will convert it back into arginine, and then you can try and make nitric oxide. Well, L-citrulline is, in the rinds of watermelon. And some people, it works. Again, it's kind of a backdoor way, and it doesn't work for everybody. And so then there's products that, were oral dissolving lozenges, and they work for some people. They help recouple that endothelial nitric oxide synthase enzyme, but it doesn't work for everybody. And it may only work for, like you said, 6, 8, 12 hours. Well, you want to have healthy arteries for 24 hours. So some people, this product works better for them for that reason.
Thank you very much. And yeah, it's just about two different pathways if you can think about it on that side of things, right? So there's the nitric oxide is NO, as you can see on here on this talk here, but NO3 is what you get into the mouth, and then you drop it to NO2 and then NO. So that's a better pathway to go down versus the old school way of L-arginine, L-citrulline. So yeah, I mean, there's a lot of people that still talk on that pathway, but it is old school data, and you're right on talking about that generation. I'm going to go through some of the questions here then, Dr. Twyman, and then kind of answer them, I guess, with you along the way and kind of go down
Sure.
there. So thank you very much, Andy, for that conversation. And both Arterisol and Vascunox is available at the HeartFit Clinic, and so this is something that we can talk about you obviously got this message, and so if that's of interest to you, then we can get that to you guys. But let's talk about this, because is low libido in women associated with low nitrous oxide? So it's not nitrous, it's nitric, but that's okay. Can you comment about that, like low libido?
It potentially can be affected, but it's more often due to lower testosterone levels in women that drives that part.
Mm-hmm.
But having issues with like arousal, nitric oxide can play a role.
Yeah. And that's where I think you had a great slide on there with hormonal imbalances. That's what I just wanted to talk about that. So looking at hormonal imbalances is very important when it comes to when we're talking about libido as well. So that's an important thing that you can look at. But yeah, nitric oxide is an important element to help dilate and improve the vascular system. Of course, with Arterisol, it's a very important, powerful thing on that side of things. Thank you. So nitric oxide is heavily involved in the microcirculation, which is important for every organ. So I think Carolyn was just answering that part of it. What are your thoughts on Dr. Ray Pete's comments about nitric oxide interfering with the ability to oxidize glucose?
I haven't seen that particular literature, and I've, at least in clinically, my experience, using these products for, over 2 years, I've not seen that to be the case.
Another question and stuff that we do in both our clinics, is there a test to determine if your glycocalyx is damaged? Maybe comment on that one there too, Dr. Twyman.
That's a good one. But there is not anything that directly looks at the glycocalyx at this time. As I mentioned in the talk, there are some research studies that look at like the breakdown products of the glycocalyx. You can look at the glycosaminoglycans in the urine and the blood, but that doesn't necessarily tell you where those are coming from. So you got to kind of look at the things that are downstream for that. So if the glycocalyx is damaged, then you're often going to have endothelial dysfunction. So you have to look at the things that affect nitric oxide pathways. So there's tests that look at arterial elasticity. There's a test called the endopath, which shows, when you have blood flowing over the arteries, well, how much nitric oxide can get released. Blood pressure is a good surrogate for it. If you have a normal blood pressure, you're more likely to not have normal nitric oxide levels. But if you have high blood pressure, you may have very low levels, and you got to figure out why that is. And then, you can look at certain blood markers. So asymmetric dimethylarginine is one of them. Homocysteine, uric acid. A cheap way is a urine microalbumin creatinine ratio. If you're leaking protein in the urine, the glycocalyx of the kidneys is getting impaired.
Yeah, I'll even keep it more simpler, like even just looking at things that can affect the glycocalyx. So having high hemoglobin A1C, just simple things like that are very important to be able to see, what can be affecting the glycocalyx as well. So yeah, thank you very much. Can you talk quickly about heart medications and the supplements, I guess, that we have here below us, with Arterisol and Vasanox? Are there any interactions that we need to be worried about with this?
With arteriosol, not really. Haven't seen much, but with Vascular, you do have to be a little bit careful if people are on other blood pressure medications.
Mhm.
If they have elevated blood pressure, Vascunox can help lower more the diastolic than systolic, about equivalent to what one of the medications would do. But you have to be working with somebody who knows how to be like, okay, well, if you're on this and your blood pressure starts dropping, which one are you going to peel off first? Because if the person has healthy nitric oxide levels because you repaired what was damaging it, they may ultimately not need the Vascunox part, but you do leave the arteriosol part on to kind of, again, like keep that gel coat healthy.
Yeah. Yeah, and it's I think one of the questions specifically was about digoxin. I don't think I've ever seen any studies on or any literature on how the pathways of digoxin could affect that, but maybe you can comment.
Yeah, I mean, digoxin has a lot of drug-drug interactions. I mean, it's, I still see a few patients on it for more atrial fibrillation. I don't see as much for heart failure anymore, but I don't think there'd be any major ones off the top of my head.
And then I think there was some questions about I think these products, yes, they are available in our clinics here in Calgary, so that's important. You can take, talk about Vascunox and medications like amlodipine. We do a separate talk just on blood pressure. So if you're one of our patients and you want that talk, I can give you a separate talk just on talking about the layers of the medications that Dr. Michael Twyman was just talking about there. And so ACEs, ARBs, calcium channel blockers, and diuretics. So we can just talk about that side of things quickly. I don't know what your pathway is in terms of treating that, but that's kind of, it's about understanding. And again, I'll get into that talk. So for those of you who are interested in that blood pressure talk, I'll send that separately because I think that'll answer that question very well. Just on the interest of time on that side of things. But I guess quickly, Dr. Twyman, what is your pathway as to how you use, talking about the RAS system quickly, but what is your pathway that you like to use in terms of treating blood pressure?
So I have a device in the office that measures central aortic blood pressure, and that's the blood pressure that your heart, brain, and kidneys are sensing. And so the ACE, the ARBs, and the calcium channel blockers, those are the workhorses that lower central aortic blood pressure. The diuretics lower your brachial pressure. The beta blockers, unless you're using the newer generation like nebivolol and maybe even carvedilol, you're really not getting much lowering of the central blood pressure with the older school beta blockers. So for the most part, it's an ACE ARB plus minus the calcium channel blocker, most likely amlodipine.
Yeah. And then I guess there was a question about allergies to sulfate drugs with Arterisol. I haven't heard that at all, but I'll let you comment on that.
I haven't heard of that myself.
Studies show carrying lipids contribute to arterial blockage. Yeah, so studies show that ApoB fat-carrying lipids can also contribute to arterial blockage. Does Arterisol have any effect on ApoB? I'll let you answer that.
So not directly, it will not lower ApoB. It may potentially help prevent the ApoB from oxidizing. So if you have access to an oxidized LDL or an oxidized phospholipid ApoB lab test, that might improve when you have healthier nitric oxide levels because you're preventing some of the oxidative stress. But the way to think about it is that you just want to have a healthy protective gel coat. If you have the healthy protective gel coat, those lipoproteins are less likely to retain in the underlying intima then.
Yeah. And these two products have no effect on lipids. Remember, we talked about that just prior to this, is that lipids, so there are different types of size particles and all that part we talk about, but the lipids themselves, remember, they're just an innocent bystander that goes to a damaged endothelium and glycocalyx. And so that's so the idea is to fix the root cause, and this is where it's getting to the root cause of improving the glycocalyx and improving the nitric oxide production as well. Takes us to another question here in terms of what's more important for vascular health, is getting a nitric oxide and endothelial function in check, or is it resolving hormonal imbalances such as low testosterone or low estrogen for that matter too for women?
I mean,
I think they're both.
the short answer is you can do both, but
Yeah.
like if you were painted in a corner so you can only do one, you got to take care of the arteries first, because if you don't have healthy arteries, you're not going to be able to get blood flow to the gonads to make the hormones that you're wanting the body to make.
Yeah, and I'll take it a step further, is that when you have good artery health, you're able to then obviously exercise and then exercise, you're getting the benefits of that to be able to improve hormonal imbalances. So I'll agree, maybe leaning to one, but I think you're going to get a little bit, obviously addressing both is definitely important to artery health. And that, again, going back to your slide on hormonal imbalances as one of those markers that can affect the glycocalyx is super important. Do these supplements improve a person's ED at the age of 58? I mean, improve
The
anyone
answer
at
is,
any age,
yeah, I
but
mean,
yeah.
I mean, I know Calibrate has a study on that, at least in progress, and there's data that it should. And definitely anecdotally, I have patients who say this, works for them. But the quick side note is like, when patients tell you that they're taking, Cialis or tadalafil, that's on my kind of intake form. Yes, there's a recreational use that some people use it for, but there's people who are like, I cannot have an erection without this. Well, it tells me that, okay, there's an issue with their nitric oxide pathways. And unfortunately, sometimes these drugs don't work for guys. And they're like, why not? Well, it's like a funnel. You're not having any nitric oxide go into the funnel. So these medicines have nothing to keep around. That's how these medicines work. They don't give you nitric oxide. They just prevent it from breaking down. And so the Vascanox has another component, hydrogen sulfide, which acts a little bit like a phosphodiesterase inhibitor. So some guys will report better erections with the Vascanox component of it.
Yeah. I guess what specific biomarkers could someone expect to improve taking these supplements? There's a whole list, but I'll let you maybe pick some if you want there.
Again, it's the ones that tend to be the ones that damage the glycocalyx. So it's going to be the oxidized LDL, the oxidized phospholipid ApoB. It may help lower, the homocysteine, ADMA, the STMA levels, because some of these products have a little bit of methylated B complexes in them to help with homocysteine. Uric acid these don't directly lower uric acid, but that's something that you'd be wanting to monitor as well, because the uric acid is going to be damaging the glycocalyx.
So yeah, and there's a question on what other beta blockers besides metoprolol. I think you can just Google all that, but there are older school medications on beta blockers. Both of this talking about, I don't think beta blockers have an effect at all on vascular remodeling. So I don't know if you want to echo that at all, Dr. Twyman.
I mean, I don't know if Nebivolol would not, because Nebivolol has certain pathways which actually improve nitric oxide. So that's why I tend to use that one if I'm going to go down the route of using a beta blocker for hypertension. Now, there's different reasons people have, heart rhythm issues that metoprolol probably works better for that. And if they have, heart failure, often you're going to be using, toproxel or carvedilol, because the data is really harder. Heart outcomes are improved with those two classes of beta blockers.
Excellent. I had a question here privately, just with cholesterol or statins. How do I get off my statin? I think that's a loaded question, but maybe that's a webinar on its own afterwards later. But I don't know if you want to give a quick couple.
Like how many hours you guys got? But I tell people, statins are tools. They work for some people. They don't work for everybody. But there's more benefits to the statins than just lowering cholesterol. They're anti-inflammatory. They have been studied, mostly rosuvastatin, at helping support the glycocalyx. It actually makes the glycocalyx thicker. So if you're going to pick a statin, pick ones that have been studied to actually have an effect on the glycocalyx. That being said, the people who tend not to tolerate statins are patients who have hypothyroidism, low CoQ10, ApoE4 alleles, vitamin D deficiency, extremely common, probably where you're at. If your vitamin D is not 60, you're much more likely to get muscle symptoms on any dose of statin. And then there's other genes you can look at. There's a particular gene called SLC01B1. And if you have that abnormal SNP, 3 to 4 times fold increased risk of having muscle symptoms on statins. So maybe don't use it in that individual. In my practice, I use a lot of Boston Heart Labs. There's a test called the cholesterol balance test that looks at desmosterol levels and lanthosterol levels. If those two are elevated, then statins tend to work better for those patients. If those levels are already optimized, probably not going to work better for them. So use a PCSK9 inhibitor or use ezetimibe in those individuals. So it is completely individualized to the person sitting in front of me.
That's great. And then I think there's another question here. If a person's taking T-Drive or Blood 7, I've heard of that before, but is it good or bad for a person with heart disease?
I'd have to know more about it because I haven't seen
I-
that one before.
Yeah, I don't know what's in ingredients of those ones there, so I don't know if we can comment on those ones there, but yeah. Yeah, so thank you very much. I think I'm gonna I'll end there because we can have a lot more. I got a few more questions there, but I'm gonna try and get to them afterwards there. But just in the interest of time, and thank you for your time today, Dr. Twyman, and I appreciate your time. Thank you, Andy, for coming on the webinar and talking about the products. I think those are super important. One thing I really like about Arterisol that I don't think was mentioned today is in terms of the benefits of Arterisol, is improvements in the lipid-rich necrotic core, and I know that wasn't talked about today, but I just want to maybe finish on that part. Is that the lipid-rich necrotic core is the consistency of that pimple? So can you talk about the studies that show the benefits of lipid-rich necrotic core on the Arterisol?
So I know they were using the MRI plaque view technology to look at that. That technology isn't readily available in most cities, but the MRI plaque view was looking at the types of plaques that are in the carotid artery. So you can have this lipid-rich soft plaque, the more inflamed plaque that's potentially more likely to rupture, or you can have more fibrous calcified plaque. Now, there's a similar type of technology for the heart, using clearly AI software to look at CT coronary angiograms. And to say, twist of fate, I'm actually going to get a clearly scanned tomorrow to look at my scan. I had one about 2.5 years ago, and I'm trying to treat some of the soft plaque with these type of products. So I should know in a week or two how much that lipid plaque shrank.
Yeah, well, we look forward to kind of hearing about those results there. So it's always nice to see a study N of 1. I think that's always powerful to be able to look at those type of things on that side of things. But yeah, it's always important to be able to look at that side of things. What kind of just in terms of that, what kind of outcomes do you see with vascular support, I guess, when you start to see that, when you start to see people change that?
I mean, within days, you start seeing improvements in the arterial elasticity. The blood pressure starts to improve within a couple of weeks. And then, in my clinic, I often will do the carotid intimal medial thickness scan pretty much yearly on patients. And you don't always see plaque regressing within 1 year, but often you see no more worsening. You see the intima stabilizing, and often then you start seeing the intima shrinking down.
Excellent. Well, once again, thank you, Andy, and thank you, Dr. Twyman, for your vast knowledge today and talking about these great products, and more importantly, about the importance of the glycocalyx and nitric oxide to arterial health. These vessels go around the world almost 3 times, are so important. And so we look forward to, of course, continue to provide you some great information to help you prevent and reverse cardiovascular disease by focusing on some great tools to be able to help you with that. So thank you very much for your time today, and we look forward to answering more of your questions if you have by email. We look forward to helping you there. Have a good night, and we look forward to helping you live happier, healthier, and longer.
Thank you all. Bye.
Thank you.